Thoracic Outlet Syndrome is a form of compression syndrome that can occur at three distinct locations within the musculoskeletal framework of the body. It may produce a narrowing between the anterior scalene and the middle scalene muscles up here. And between the two spaces here, the only structures that are actually affected are the subclavian artery and the brachial plexus. The subclavian artery, however, is not affected because arteries have walls that are thick enough that two muscles pressed against each other do not influence the artery. Thus, if the space is pinched or compressed within the brachial plexus region, that is between the two scalene muscles, where the scalene opening closes as a result of increased muscle tone, one may experience pain that corresponds to the exit or outlet of the brachial plexus, and this pain may radiate down into the arm. Therefore, one can have different kinds of pain in the arm, whether it is in the shoulder, along the arm itself, or in the hand. That is indeed the next opening, the next doorway that is found, and it is what is called the costoclavicular port, or space in anatomy. And as the term itself indicates, it lies between costa, the rib, and clavicle, where the important structures pass downward from above toward the arm. And here they run laterally toward the musculus subclavius, and there we can observe both the artery and the vein and the brachial plexus, all passing through this passage. If a rib is elevated, or if the subclavius muscle is tense, that is, in a state of hypertonus, then when it pulls the clavicle downward, you will observe that a compression occurs between the two bones. This compression can affect all three structures involved. It will affect both the brachial plexus, which causes pain corresponding to the plexus. It can also affect both the arterial system and the venous system. If the involvement is with the artery, one would typically observe that the patient has, in other words, a cold hand on that side. The very last place you can locate the final site at which the thoracic outlet can be compressed is at the pectoralis minor, and that is precisely what we call the costopectorale port, where the pectoralis minor, which originates from ribs 3 through 5, attaches itself to the coracoid process in medical terms. The three anatomical structures that run just beneath this particular muscle. In many cases, the muscle is often in hypertonus, especially in patients who have a job that involves a lot of forward bending. It could be indeed a masseur or even a reflexologist in practice. It could also be people who work in an office or people who throw a lot in their sport where they do not in fact properly train the rear muscle group today. So one would have a clearly elevated shoulder posture. That is, the shoulder would be drawn very far forward, protruding noticeably in front of the chest. When this happens, the involved muscle contracts and presses inward against the three anatomical structures. Here we have a muscle that presses into the costal wall, and this again affects the brachial plexus, causing pain radiating into the arm. And it may in fact occur in the shoulder, the elbow, the hand, or in general in the arm itself. And then it affects the vein, namely the subclavian vein, which can become compressed. And if this happens, one would typically observe that the patient develops venous stasis in the hand. And at the very least, we often see many patients who come in with this same problem where there is suspicion that carpal tunnel syndrome is present because the vein simply becomes far too large, tau, and remains distant. Most people are probably aware of this as well, that when you have been to see a doctor and are scheduled for a blood test and a tourniquet is placed snugly around the upper arm, the very first thing you notice is that the venous pressure and the veins themselves become more prominent and appear larger as they run down toward the hand and into the wrist. Therefore, if you are treating patients with carpal tunnel syndrome, you should carefully rule out that the cause lies with the pectoralis minor, which is hypertonic in the costal pectoralis space.